All right, so welcome everybody. Welcome to Chicago. My name is Dr Schaaf. I'm a clinical geneticist. I used to work at Texas Children's Hospital and Baylor College of Medicine for 12 years. But 4 years ago, my family and I moved back to Germany, where we're from originally. And I'm now the department chair of human genetics at Heidelberg University. And my team and I actually brought 3 students and 2 postdocs from my lab. We've been enjoying Chicago for a couple of days. We've done some sightseeing, and we have had 2 amazing days of research conference that just ended this afternoon. All of them have given presentations at the research conference, talking about their work on MAGEL2 and Schaaf-Yang syndrome and how it relates to Prader-Willi syndrome. And then this afternoon after lunch, we had a research roundtable where we got together with 25 researchers from all over the world who are all interested in MAGEL2 and have various projects on Schaaf-Yang syndrome and MAGEL2. And it's been amazing to kind of see that group, see all the amazing people and ideas and their dedication also to Prader-Willi and Schaaf-Yang. And we talked for almost 2 hours to hear from each other what we are doing, which challenges we are experiencing, and what we can do together as one big team to kind of further advance the research, our understanding, and potential therapeutic avenues for Schaaf-Yang syndrome and Prader-Willi syndrome. And it's been a very rewarding experience. But my favorite part is now when I meet you all and your children. I mean, this is really what I've been looking forward to for the past 4 years, because the last conference that I attended in person was the one in Indianapolis, I think, in 2018. Was Vegas after Indianapolis? Yeah. Oh, okay. Then the last one was Vegas. So I got that mixed up, but it's been too long anyways. And it's wonderful to reconnect with many of you who I've met before, and also to meet many of the new families who I hadn't had a chance to meet in person before. I know many of you have emailed me, and with some of you I've talked over Zoom or Skype, but it's nothing like getting to see you and your precious children in person. So I'm most grateful for you and your efforts of coming here. I know it's challenging to travel with children. I have 4 children myself, and I hate traveling long distance. It's always challenging. And then when you have special needs children, it can be even more challenging. So I know that it's like an extra level of effort that you've gone through, and I'm so grateful that you're here, and I'm so grateful that we can meet and talk to each other. The next hour or so, should really be for you, and you can always stop me and ask questions in between. The way that I've conceptualized this is I have prepared a presentation that gives some kind of basic knowledge about MAGEL2 and Schaaf-Yang syndrome, especially for those families who are here for the first time and feel like they don't really have a great understanding of what this gene and protein and syndrome really means. But I've also included some new information, some of the things that we found out just over the last couple of years. And I'm tagging team with Laura Deutsch. Laura is a medical student in my team, and she's been working with me and my group for the last year. And Laura has had a chance to analyze some of the data from the patient voices study that many of you have participated in, where you went through like extensive questionnaires, and she got all that de-identified information, and she's been working her way through that, and she'll be presenting some of those data today, and then I will finish up. But again, this is not for us, this is for you. So if you have questions, just, raise your hand, and I'd be happy to answer your questions in between. Oh, Emma is raising her hand already. Yeah. Awesome. Yay. exactly. And then if we finish early, then we can just talk and maybe take more pictures, whatever you want. Okay, so how it all started. I mentioned this before. I was never meant to be a Prader-Willi researcher. I am, and not let alone a Schaaf-Yang researcher. I'm just a clinical geneticist, and I practice at Texas Children's Hospital. I kind of specialized in the genetics of autism spectrum disorder. And in 2012, a patient came to my clinic. He came from Arizona. He was, I think, 13 years old at the time, and he had autism spectrum disorder. And, I was tasked with finding the cause of his autism. But when his mom and he came to clinic, she actually said, what I really want to find out today is if Donnie has Prader-Willi syndrome. And I really didn't understand that because he looked nothing like Prader-Willi. But then she explained to me that Donnie was born with severe hypotonia. He had feeding difficulties. He had a club foot. He had an undescended testicle. He needed to be tube fed. And the physicians in the NICU thought that he looked very much like a child with Prader-Willi syndrome. So they ordered the Prader-Willi test at the time. They came back negative, and they sent her home when Donnie was better, saying, well, the test was negative, but he still looks somewhat like Prader-Willi. So for 13 years, she had that in her mind, like, he has something like Prader-Willi, but we couldn't figure out. And we did genome sequencing on Donnie and found a mutation, a point mutation in the gene MAGEL2, which is one of the genes that plays a role in Prader-Willi, and I'll go into that in just a few minutes. And he was my patient number one with a MAGEL2 mutation, and we quickly identified 3 more. And once we had 4, we wrote it up as a scientific manuscript, submitted it to Nature Genetics, and it was published in 2013. And that was really the beginning of this journey. At that time, I had no idea whether in 2021 or 22, I would have still 4 patients or 5 or 6. And, it's mind-blowing to me and amazing to see that we're now in touch with more than 300 families across the world, and the amazing community that you all, and we have contributed a little, have built over the course of less than 10 years. So MAGEL2 is a gene within the Prader-Willi syndrome domain. This is an area on chromosome number 15. And when you lose a chunk of material in this domain, or if you get 2 copies of chromosome 15 from mom and none from dad, then you have Prader-Willi syndrome. How do you get Schaaf-Yang syndrome? You get Schaaf-Yang syndrome when you have a point mutation in just one of those genes. So if you think of the whole region as, like, let's say you have a library, and in the library you have 15 bookshelves, and one of them is number 15, chromosome 15. You get Prader-Willi syndrome when you're missing a whole kind of row of books on that bookshelf. In Schaaf-Yang syndrome, you have all those books. The shelf is okay, the books are okay. It's just in one of the books, the book for MAGEL2, there's a typo. It's just typically one letter that is changed, but it's an important letter and has, really, important consequences when that letter is changed. But when you have a typographical error, like a missense, a point mutation in the MAGEL2 gene, then this can lead to Schaaf-Yang syndrome. It's a particular type of mutations that we talk about. Up until now, most, if not all, of the patients with Schaaf-Yang syndrome have what we call a truncating mutation, which means it's a mutation that leads to a stop somewhere in the gene, which means when the gene is translated into a protein, it leads to a stop and the protein is truncated. That's why we call it a truncating mutation. It's also important to understand that there's something special about this region on chromosome 15 because it's imprinted. So imprinted means even though we all have 2 copies of chromosome 15, one from mom, one from dad, only one of those copies is used for that particular area. It's the father's copy that's used. So the chromosome 15 that we get from our dad, that area is transcribed and then translated into proteins, and that's the active copy of chromosome 15. The copy that we get from mom is silenced. It's almost like those books behind a wall, or they locked away and they're not used. So even though you may have like perfect instructions from mom, they're not used because only dad's copy that you got is used. So if you have a mutation in dad's copy, then you develop Schaaf-Yang syndrome. If you have a mutation in mom's copy that you got from your mom, then you are actually healthy. Yes. Right. So so this question, I have to repeat the question for the recording. So Matt is a question, how about the other regions on chromosome 15 or the other genes within the Prader-Willi locus? Are they also affected, right? That's your question? Other areas. Yes. So it's only a small region on chromosome 15 that's imprinted. It's those genes and RNAs that are shown in blue here. Those are maternally imprinted, paternally expressed. Then we have this region here in red, which is the Angelman syndrome domain. That one is paternally imprinted, maternally expressed. But for Angelman syndrome and UB3A, only in the brain, not in the rest of the body. So genetics and biology in medicine is complicated. You know, one reason why we have to go to med school for many years and pay a lot of money, at least in the US. You know, we have to have a reason for that. Yeah, it's complicated, but it's only this small region that's maternally imprinted, paternally expressed, and then all those black ones and everything else on chromosome 15 is not imprinted at all. Yeah. So what we realized when we identified those first individuals with MAGEL2 mutations was that there's a lot of clinical overlap with Prader-Willi syndrome. So it's not only that these are molecularly or genetically related, also clinically, you know, there's a lot of overlap. And, you know, when we try to put it into a graph, this is a graph from many years ago, we felt that the overlap is mostly, you know, what the kids look like when they're born. They look really much like Prader-Willi. They have hypotonia, they floppy infants, they have feeding difficulties. Many of them need to be tube fed. Some of them get like a G button because it doesn't resolve quickly. And then when they get older, we see delay in developmental milestones. When they get older, most of them, if not all of them, have intellectual disability, and also an overlap with Prader-Willi syndrome, easy to recognize in the boys, not so easy to recognize in the girls, is hypogonadism, underdevelopment of the gonads. Especially in the males, what we see is oftentimes the boys have undescended testicles, and they can have a small size of the penis because the sex hormones are altered and don't lead to the full development of secondary sexual stigmata. But then there were also differences between Schaaf-Yang and Prader-Willi. We felt, especially early on, and especially looking at the younger kids, that a lot of the features that are considered very typical for Prader-Willi, the overeating, which is called hyperphagia, and the development of really severe obesity, we did not see in our Schaaf-Yang patients. On the other hand, in Schaaf-Yang, we had a much higher prevalence of autism spectrum disorder. Almost 4 out of 5 kids with Schaaf-Yang get an autism diagnosis. And then something that was really striking and visible were the contractures, especially the contractures of the small finger joints, but in the more severe cases, contractures also affecting the elbows, the knees, and other joints of the body. So we felt, you know, while there was overlap, there were also distinct features for one and the other. Like I mentioned, you know, we're in touch with approximately 300 families with MAGEL2 mutations now. And we've cataloged all those mutations. We've done extensive studies to better understand the clinical manifestations. What really stands out is that there's one hotspot, so this big circle here in the middle, where most of the mutations happen, and approximately half of your children have the same exact mutation, which is C1996 DUP-C, which is the addition of one letter C in a stretch of letters right in the middle of the gene. But, mutations can be anywhere in the gene, and when they're truncating, they probably lead to Schaaf-Yang syndrome as long as they are on the paternal copy of the MAGEL2 gene. This is important, that whole idea of imprinting, and that they have to be on the paternal copy to develop the features, because Schaaf-Yang syndrome can run in families, and some of you, have had more than one child with Schaaf-Yang syndrome, or have had family members like, where the affected child has a cousin, or even more distant family members who are also affected. So in fact, like there's one family that we've been in touch with in Europe, they have 16 family members with Schaaf-Yang syndrome. Now, why is that? And why, are there unaffected individuals passing the mutation to affected ones? So as long as the mutation runs in the maternal line of the family, nobody will be affected, because each and every person who carries the mutation on his or her maternal chromosome 15 will show no signs whatsoever. But when a dad who carries the mutation passes that mutation on to his children, and it doesn't matter whether they're boys or girls, they will be affected. So this has implications for family planning and the chance of having additional children with Schaaf-Yang syndrome. For each and every one of you, once you had an affected child, the dad should get tested to find out whether the dad carries the same MAGEL2 mutation, because it does really make a difference. If dad carries the mutation, for each and every subsequent pregnancy, the chance will be 50% for the child to inherit the mutation and get Schaaf-Yang syndrome. If dad does not carry the mutation, then the chances are much lower. In fact, we say, they're less than 2%. It's never zero, so that's another lesson about medicine and biology. Nothing is zero, nothing is 100%, nothing is black or white, but it's a very low chance of having another child with Schaaf-Yang syndrome. And I can go into more details if you're interested why that is and why it's still increased compared to the general population. So let's talk a little bit about the clinical features. The title of the talk is Schaaf-Yang syndrome across a lifespan. So what does it look like? It can actually manifest prenatally. So when we ask you, did you notice anything during the pregnancy? Some of you who've had multiple pregnancies will report that there was decreased fetal movement. And sometimes with decreased fetal movement, there's also a buildup of fluid leading to polyhydramnios, so excessive amniotic fluid, which can be related to the condition. And then also, prenatally, the doctor who's doing the ultrasound may notice kind of physical findings, such as contractures. So in some of the prenatal cases, we've actually seen the contractures of the hands, and certainly in some of the more severely affected cases, also the contractures of other parts of the body. But when it really becomes evident, and I think for each child in the room, it became evident quickly that something is different about that child compared to all the neurotypical children, is typically the low muscle tone that is noticed within the first week of life, so muscular hypotonia. Most, if not all, of the kids have contractures, typically of the small finger joints. Many of the boys have undescended testicles. And then the feeding difficulties. We believe that the feeding difficulties are related to the hypotonia and oromotor dysfunction and the challenges of coordinating the process of swallowing. So a lot of kids actually need to be tube fed, at least for a while. And then when kids older, we do see the developmental delay, which ultimately leads to intellectual disability. And many of the kids have altered social interaction, and many of them get a diagnosis of autism spectrum disorder. But there are more features to Schaaf-Yang. So sleep apnea can be an issue, and we've done some studies with Seattle Children's who've analyzed sleep studies of many kids, and they see that it can be obstructive sleep apnea, which is again related to hypotonia. But in many cases, it's also central sleep apnea, meaning a dysfunction in the brain where there's decreased respiratory drive from the brain to the periphery. So, and it can be a combination of both. It's really important when your child is diagnosed with Schaaf-Yang syndrome to get a baseline sleep study, because unfortunately, we have lost some children with Schaaf-Yang syndrome over the course of the years, and some of those kids died, during early childhood due to sleep apnea. They basically stopped breathing. So, an assessment of sleep apnea is certainly important. And, I don't want to scare you, but every child should get like a baseline evaluation. And then, that sleep doctor will determine whether you need to follow up and how often you need to follow up, etc. Respiratory problems beyond apnea can be an issue, especially during the first years of life. Almost 3/4 of all kids have had some kind of respiratory issues. Some required intubation. Almost half of them were intubated at some point, and about 1 in 5 requires a tracheostomy, at least for a while. Most, if not all, of the kids get off the tracheostomy at some point, and that's also one of the positive messages that I want to bring across, that generally speaking, the kids have the most challenges when they're young, and they're medically most complicated in the first years of life. Once you've overcome that phase, it actually gets somewhat easier. And when you talk to families who have kids who are now teenagers with Schaaf-Yang syndrome, they will tell you, oh my goodness, yeah, nothing compared to those first years of life when we spent so much time in the hospital, oftentimes in the intensive care unit, and we haven't been to the hospital in a long time. They still remain somewhat respiratorily fragile. So when they get respiratory infections, also because they have more secretions and they still have hypotonia, they are at an increased risk compared to the general population. So I always feel like, have a little bit of a lower threshold going to the ER, having that kid checked out when he or she has a respiratory infection that impairs breathing. When they have labored breathing, take them to the hospital, have them checked out. But it actually gets better over time, and the kids get like physically much more stable over time. Feeding problems, almost everyone has experienced. Dysphagia, so altered swallowing, is seen in almost all of the kids, and 3/4 have been tube fed. Some get a G button, but again, it seems to get better over time, and many of the kids get rid of that G button. So when you look at the 10-year-olds, it's actually a small fraction of 10-year-olds who still have the G button or depend on the G button. Some families, and that makes sense, keep the G button for a while just as kind of a lifeline. If it goes south, then you still have that. When the kid's sick and doesn't want to eat, you can feed them through the G button. But at one point, most kids get off. Okay, so the hands of Schaaf-Yang syndrome, this is really something that helps physicians recognize the syndrome. Because many of the kids have the contractures, they also have the tapering of the fingers, and this has led to situations where physicians in the NICU actually saw a hypotonic child. They look at their hands and they say, oh, I've heard about this. This is Schaaf-Yang syndrome. We don't need to do exome or genome sequencing. We'll just sequence MAGEL2, and they identified the underlying cause. There's more to the bones, and we just talked about some of that. So scoliosis is an issue. Scoliosis is one of the few phenotypes that seems to get worse over the course of the years in many cases. So some of your kids have had surgery to fix the scoliosis. Harold van Bossie, who's one of the leading experts on scoliosis surgery in Prader-Willi syndrome and Schaaf-Yang, is here at the conference, and he will be giving a talk tomorrow. He's certainly a good resource for that. And then in a study that we did at Texas Children's Hospital, we also found out that a lot of the kids have decreased bone mineral density, sometimes to the point that they have, clinical osteoporosis. And we've certainly also seen that in the Facebook group, that, some of the kids have had broken bones, even without adequate trauma. They have fragile bones, and, it is in part because it takes them a longer time to become mobile. And if you don't walk and bear weight on your bones, they don't mineralize as well, and, they tend to break more easily. But it also seems to be something intrinsic to MAGEL2, because there's a group in Israel that has investigated that, and the cells that build bone and kind of rebuild bone, their function is altered. And so there's something molecular that explains also the altered bone formation in Schaaf-Yang syndrome. So I do.
Will they eventually catch back up after it? Or is that?
Yes. So, we have not done any. So the question that Leslie is asking, whether kids who then start walking, whether they catch up and kind of get into the normal range. We have not done any longitudinal study where we have assessed them multiple times over the course of several years. I think from like a general understanding in medicine, I would expect that they can catch up somewhat and that their bone mineral density will improve when they weight bearing and moving. But it may not make it all the way into the normal range. Our recommendation is to get a DEXA scan or an assessment of bone mineral density when the kids are 5 years old, because that's when you also have normal ranges that you can compare them to. And if the bone mineral density is decreased, to also look at vitamin D, calcium levels. These are things that you can substitute. And, in the Western Hemisphere, almost everybody is somewhat vitamin D deficient. So have that checked out and optimize it to get into the normal or high normal range. Don't give too much, because too much vitamin D can also be toxic. But optimize calcium and vitamin D intake. And if it's really bad, then talk to your orthopedic surgeon or bone doctor about other options. There are obviously medications out there to treat osteoporosis in the general population, like postmenopausal women, and some of those medications may also apply to children who really are far outside the normal range. Matt, you had a question. Okay, so the question was anything you can do about early intervention. So even before they turn 5 and you can do a DEXA scan, you can have vitamin D and calcium assessed. So that's something that you can check early and optimize early. Yeah. Then, what about adults with Schaaf-Yang syndrome? We had no idea for many years what those individuals would look like, and what are the things that they struggle with. There's a publication that Felix Marbach, who's a physician in my team, coordinated that we published in 2020. And we presented 8 individuals, all adults with Schaaf-Yang syndrome or mutations in the MAGEL2 gene. We always separate number 8 out a little bit because it's a different mutation. It's not a frame-shifting mutation. But looking at these individuals, and you see pictures when they were young compared to when they are older, what we do appreciate is that the clinical manifestations somewhat change. Clinically and medically, they become more stable. Respiratory issues become more stable. Apnea becomes sometimes less of an issue. Feeding gets better. They come off the G button. Developmental delay and intellectual disability are there to stay, and most of those individuals have intellectual disability, at least in the mild range, some in the moderate or more severe range. And then something that we had probably underappreciated in our early studies based on the younger kids is that overeating and the lack of satiety and obesity can become an issue as they get older. So looking at this table here, we have BMI in that first row. You see, BMIs mostly between the kind of 30s and 40s, which is outside of the normal range. So it is something that to keep an eye on. And it appears that this overeating and the development of obesity is at an older age compared to Prader-Willi syndrome. Most kids with Prader-Willi develop that overeating and the obesity when they're like 6, 7, 8. It gets better with growth hormone and rigid kind of control over their diet and kind of exercise program. In Schaaf-Yang, it appears that this happens later, but it may happen in a substantial number of patients. Roya, you had a question. Yes. So the question is whether this would also be considered hyperphagia. So hyperphagia is a descriptive term and it just means overeating or over swallowing, right? So eating too much. It is, we have not done a systematic study to evaluate that, but what we hear from families is that a lot of your kids do not have a good appreciation of satiety. So if you keep offering food to them, they may continue to eat. They're not as aggressive as Prader-Willi patients in their food-seeking behaviors, where they get up in the middle of the night, go to the fridge, eat everything that's in the fridge, which is really scary in Prader-Willi syndrome. It doesn't seem to be that severe in Schaaf-Yang syndrome. In the younger kids, and this also relates to their cognitive function, many kids with Schaaf-Yang syndrome are cognitively lower functioning than Prader-Willi. So they may be at a point where you, as a parent, still control what they eat because they eat what you give to them. They are not actively asking, searching for food, getting food, sneaking food from their classmates. You are in control of that. But as they get older and continue to develop cognitively, they also, become more active about certain of those behaviors, and they may be developing food-seeking behaviors as well. So, and that's actually listed in the second column here. So, overeating is mentioned here. So overeating could be used as a synonym for hyperphagia. And you see, some of these really do overeat. Some of them really do have food-seeking behavior. We have some adults with Schaaf-Yang syndrome who live in group homes, and where we hear that, they get up and they go to the group's fridge and eat at night. Not as severe as Prader-Willi, but they do. So it's certainly something to keep an eye on. And as soon as it develops, to, consider kind of talking to a dietitian, thinking about, some families go to the Prader-Willi clinic because there's no dedicated Schaaf-Yang clinic at your children's hospital, but you go to the Prader-Willi clinic and they have that expertise of, how to manage food intake, how to come up with a good exercise program for your child. Abnormal sleep cycle continues to be an issue. So I didn't mention that before. Circadian rhythm, is altered in children with Schaaf-Yang. It's altered in the mouse model of Schaaf-Yang. It's altered even in cells that are generated with MAGEL2 mutations. They, have different rhythms compared to healthy or neurotypical cells. Because they don't sleep as well, they don't get as good of a restful sleep at night. They can be sleepy during the day. And then one other thing that we haven't touched on yet is constipation, kind of altered gastric motility, delays in intestinal passage. It just takes longer for food to go through the body, and that leads to constipation and is certainly an issue in many of the children, some of whom have good management with Miralax or laxatives. In others, it's more challenging, where they need enemas or even manual decompaction, which is very unfortunate, and something that we are keeping an eye on, and also talk to pharma about ways to better help your children kind of be more comfortable and have better quality of life. How about behavior? This is something, is all based on questionnaires, and is certainly not an extensive study of the behavior of adults with Schaaf-Yang syndrome. But, to put this into a few sentences, this slide, I would say there are a lot of behavioral issues also in adult life. And, they can include anxiety and social withdrawal. They can include depression, but also kind of aggressive behaviors towards others, hyperactivity, stubbornness, some of the things that are described in Prader-Willi syndrome, some of the things that, may be more unique to Schaaf-Yang syndrome. We have not investigated this in much detail, but, we need to be aware and help those adult individuals with Schaaf-Yang syndrome kind of get control over those issues as well, especially when they affect like anxiety and depression, where good medications are out there to help them. Okay, so I'm coming back to this old slide. And, over the years, we somewhat shifted that slide because we came to realize that some of the things that we did not consider to be part of Schaaf-Yang syndrome may be part of Schaaf-Yang syndrome, but they may just kind of occur at an older age compared to Prader-Willi syndrome. So with that, I will stop and I will hand over to Laura who will go into more detail about the clinical manifestations as you reported them in the patient voices survey, and also something that's very important for us to understand: what are the features that affect your quality of life the most, and what are the features that are most important to you for us to tackle and approach in regards of like therapeutic interventions and avenues. So I'll hand it over to Laura, and then I'll be back in a few minutes.
Yeah, okay. Hello, everyone. Thank you, Christian, and especially thank you all for having me here and for giving me the opportunity to present some of the data. This is a survey the Foundation for Prader-Willi Research conducted in 2021, and many of you may have participated in the survey. And yeah, I'll just try to walk you through what we have done with this data. So, oh, this one doesn't seem to work. Okay, so first, I'd like to present the study design of the survey. So the Foundation for Prader-Willi Research designed it with consultation of Dr Schaaf and also 2 family representatives. 81 primary caregivers were then recruited via the family Facebook group and also personal communication. And among those primary caregivers, 78 were parents, and 3 were other caregivers, so also grandparents. And actually, there were 90 different countries represented, and what's important, I only received the de-identified data, so I don't know who said what, but this is sort of a collective knowledge. And we then stratified the patients into 4 age groups. So under the age of 4, there were 26 respondents. Then between 4 and 10, there were 32. Between 11 and 18, there were 17. And we also had caregivers of 6 adults that reported back. And we did look at symptoms, but mostly we evaluated how you as caregivers perceive those symptoms, and also how you would rate the impact on your children. And our main goal was to identify medical needs and treatment priorities to check so we missed something out. And sort of a disclaimer, I may present to you some prevalences of symptoms that do not correlate, or that are not the same as Dr. Schaaf has just pointed out to you, which doesn't mean that the data is necessarily wrong, but that maybe some patients were only diagnosed later in life, so parents didn't attribute symptoms to Schaaf-Yang syndrome at that time, or they maybe just didn't occur at that time of the survey, or something that was just not as important, and caregivers didn't realize it might be an issue. And the other disclaimer is that the data I'm going to show you, or the figures, are a bit colorful, to say it in some way. So they might be confusing, and they also were confusing to me, even though I designed them. And if you have any questions, please feel free to interrupt and ask, and I'll try my best to explain it. Starting off, you were presented with 19 different symptoms, and you could state whether your child had experienced one of those symptoms at any time. And as this was a larger cohort, symptoms were, as I mentioned previously, a bit different. And we could, however, see that most of you had seen that your child had experienced developmental delay, hypotonia, or communication and speech delay and difficulties. And what was rather interesting for me at that time was that only 47% in this cohort said that their children had experienced autism spectrum disorder or had been diagnosed with this. And but what we mainly wanted to focus on was how you rated the impact those symptoms have on your child with Schaaf-Yang syndrome. And here we could see that actually the importance of symptoms changed. So when we rearranged, we could still see, yes, developmental delay or intellectual disability was the most important issue, but other problems like mental problems actually moved up in this different rearrangement of symptoms. And to start off with the cognitive symptoms, so the most prevalent issue, we could see that, yes, over the age of 10, all children had been diagnosed with a symptom, but we see an early onset. So over 90% of patients under the age of 4 actually showed developmental delay or intellectual disability, and it's quite similar with communication problems. And now this is where it gets confusing, but here we can see that the impact of developmental delay, though it is discrete, but you might see that those bars are not as high when we say, okay, what was very or most important for you as caregivers in terms of the effect a symptom has. And here we can see, okay, the impact was not always as high as the prevalence of symptoms. However, and this is also what is very important to us for us to know, caregivers were very worried about the symptoms. So if the symptom occurred, then yes, it was a source of concern for you. The one thing we also noticed was that sometimes the impact was even perceived to be higher than the diagnosis, especially in terms of communication difficulties. So here we see that at times, some patients weren't even diagnosed with a symptom, but you as caregivers noticed the symptom was there. So this is also something for us to keep in mind. For mental development, this is something most of you, especially those caregivers of you who have older children, might have experienced. So this is something that only has an onset later in life. So, for example, autism spectrum disorder, which I was surprised about at first, that it was only prevalent in about 50% of this cohort, actually does increase in its prevalence. So in the oldest cohort, 5 out of 6 patients had autism spectrum disorder or had this diagnosis, and that's 83%. And what we can also see is that many caregivers rated the impact of autism to be very important well before the symptom was diagnosed. And like with many mental problems, it is always a source of great concern for many parents. I mean, this is something that really affects the well-being of a patient on a whole different level, and I would say that's very understandable. And what we can also see is that this worry especially peaks during puberty, during adolescence, which I mean, is also something we see in neurotypical children. Yeah, I mean, this is an issue. So, and also, I mean, the worry decreases, so maybe this is something to look forward to. And so for other symptoms, so for those symptoms, and for whatever reason, my colors changed as for now, but okay, I'll walk you through it. For those symptoms, we have limited treatment options, but there are treatment options and they are mostly conservative. And this seems to be very efficient for you, especially in terms of speech and occupational therapy. So if a child received this treatment, then yes, it was actually helpful to some degree. For autism, there is applied behavioral analysis therapy. However, only about 50% of diagnosed children even benefited from this. And as I've learned yesterday, this might also be a reason that insurance doesn't cover for it or whatever. Maybe it wasn't just applicable for parents who reported. And it was also not as effective as other treatment options. Same goes for anxiety medication, though we also have to keep in mind that anxiety medication can only apply in some countries in children, and we also had respondents, for example, from Europe, where there are different restrictions. So hypotonia is sort of one of the most characteristic issues, and obviously we see that it has an early onset. Same goes for contractures, so something very Schaaf-Yang syndrome typical. And here we can see that yes, parents in the youngest cohort are very worried about this symptom because it is one of the first. But the impact, the perceived impact does decrease with age, and it becomes less important for the children. The only thing we have noticed in this cohort, and I think it's worth mentioning, that even though the impact decreases in the oldest cohort, parents have are worried about the development of the symptom, or maybe retrospective. This we cannot conclude from the data, but it's something we have an eye on. And here we could once again see that physical therapy was very effective for most patients and really helped. And if applied, splints for contractures were also helpful. In terms of eating, we see that there is this is a main issue for many parents, for many patients. And also with hyperphagia, we see that it does have an onset later in life. However, and maybe that's also because we know it's very prominent in Prader-Willi syndrome, it is always a source of great worry for parents, even well before it really is diagnosed. And still, what we can see is that most of you are more worried about having the possibility to feed your child or properly. As for sleep problems, those are also very prevalent, and breathing problems in this cohort were less prevalent, but yeah, it is also an important issue. And what we can see, once again, like with mental issues, sleep problems have the largest impact in adolescence, but even parents of younger children, so in the cohort of 5 to 10 years, are worried, apprehensive towards this issue. For breathing problems, and this is something that was really striking, even though the impact seems to decrease, the worry increases in all cohorts, and this is something we definitely have an eye on. So for therapeutic options, in cases of central sleep apnea or obstructive problems, one can apply CPAP, and even those sleep problems are largely prevalent, and we see that only about 1/3 of patients has ever used CPAP, and this might be because at this time it was still underdiagnosed sleep problems, or those sleep problems derive from another origin. Growth hormone deficiency is also very prevalent, like other endocrine issues or hormonal dysregulation, but it does not impact patients or parents that much. For scoliosis or osteoporosis, so bone-related issues, however, we see an increase in prevalence. And we also see that this is something you really worry about, and that does impact children even before it is diagnosed. And yeah, what we have to say is that the growth hormone deficiency might not be a problem, because this is actually one thing where we have a specific treatment. So most of your children are on growth hormones, and this is just the replacement. I mean, obviously there are some side effects. We have to keep that in mind, but overall it's largely efficient. Whereas scoliosis braces can be used, but this is also something we see in the general population. They are effective if used, but have significant side effects. And I mean, it's very constrictive. So overall, and I'm really sorry, for whatever reason, my slides are a bit, yeah, broken. So symptoms like hypotonia, contraction, feeding problems, and hormonal dysregulation actually lose their impact. So they get better with age, and children also don't seem to be impacted by them as much. Intellectual disability and breathing problems remain rather stable, though their importance for every individual child is obviously different. And mental and sleep issues or skeletal problems and hyperphagia increase in their importance. And even though we have seen that many treatments that are used are helpful to some degree, we can see when we ask you that you still need more treatment. And we see that for all treatment options, you were asked if they were important for you, if they would help your child. We see that well over 50% of you really stated, yes, we need a treatment here, and in most cases, well over 80%. And therefore, it's unsurprising that many of you rate the ability of a person with Schaaf-Yang syndrome to reach long-term goals, whatever they may be, as not very likely. And also, and this is something, I mean, we really have to appreciate as researchers, the impact on you as caregivers is also rather high, or very high. I mean, we can see that having a child with the Schaaf-Yang syndrome does impact you financially and socially in your day-to-day living, in the ability to work outside of home, and also in reaching long-term goals, which is something we really have to appreciate. And if I look at this data and we are wondering what we can do with it, what message does it convey, for us and also for me personally, I have to say it does motivate me to pursue further Schaaf-Yang syndrome research and to work on medical improvement, because we see that the phenotype evolves and it poses age-depending challenges that you, as in your you have the experience knowledge that you report. There are several symptoms that highly impact individuals before having been diagnosed, and sometimes you are worried about something that has not even been diagnosed, but you may have heard will occur or might occur. And while the available treatment is largely effective, we see that it is not sufficient to alleviate the overall impact, and there is a high demand for new therapeutic options. And we also see that challenges for caregivers and families are immense. And therefore, we are very grateful to you for participating in this survey, for giving us insight into what are your needs, what do you want from us as researchers. And I really want to thank Lisa for giving me the data, for communicating with me. And I also want to thank Dr. Schaaf for giving me the opportunity to work in his lab, to work on Schaaf-Yang syndrome. And also I'm grateful for my fellow lab members who are also here in Chicago and who are also working in the field of Schaaf-Yang syndrome. And now I'm very happy to answer your questions if you have any. Yeah. Yeah. Yeah.
Further development for I think maybe a lot of us
yeah
in terms of our children's development.
Yeah.
But I thought it was interesting that you took on how it impacts the caregivers. What kind of things would we be expecting or could be possible in the future for caregivers?
Yeah. So there was the question that we see that caregivers are largely affected, and what treatment or options we have for the future, or we're aiming to investigate. And yes, I mean, we've just had a roundtable, and obviously we have been discussing what we can do for children with Schaaf-Yang syndrome. And but we also know, and we're working with a foundation, and I personally work in the lab, but maybe Christian knows something that's being done.
Yes, so I think it's a first step to appreciate, right, that Schaaf-Yang syndrome does not only affect your child, but affects the entire family, you know, and it's something to keep in mind. And, you know, we always focus on the well-being of your child. When you come to us, to our clinic, we talk about your child and how it affects your child. We as physicians should not forget about the entire family. So I usually try to spend at least a few minutes asking the parents, how are you doing, right? And you as a parent, you also need to ask yourself, how am I doing? How are we doing as a couple? Because we do know that parents of children with special needs have a much higher likelihood of separating, of divorce, because it is an additional stress on that relationship. So you need to take good care of yourself and your relationship, because you need each other. You can only tackle this as a team. Nobody can do this alone. And it's much better for your child if the two of you stay together and function as a team. So that's important, right? So, you know, hug each other, give yourself a kiss. And what can we do? You know, this is actually something that has not been a main interest of like medical research or so, right? But it is developing. And in fact, you know, there have been studies, for example, at Emory University, where psychologists have investigated kind of the stress of parents who have special needs, children. And there was a beautiful article actually in the New York Times, maybe 6-7 years ago, and I can try to pull that out again and send it to you, about a program that was developed at Vanderbilt University that investigated how parents can be helped to better cope with the stress that they're experiencing. And it's a program that we actually implemented at Texas Children's Hospital, and we were offering it twice a year. It was called From Stress to Strength, where we provided one-on-one care for all the kids, special needs and neurotypical, and freed up time for 3 to 4 hour sessions for the parents to meet as a group, discuss the stress that each and every one is experiencing, and to develop kind of ideas and tools to decrease stress in everyday life. You know, it's very simple, actually. You know, some things, they have nothing to do with special needs children. They help me. And, you know, some of the lessons I took home and I teach my wife, and she always laughs about me and my ideas when I say, you know, Catherine, think about it. Stress is like the tide, you know. Sometimes you feel like drowning, but sometimes you lie on the beach and it's just beautiful. And she's like, oh my goodness, with your seminar again. You know, stress is like a roller coaster. You know, some people need stress and they enjoy it. Others can't stand it, and it's just too much. So each and everybody experiences stress differently. All of those, I mean, it sounds like, you know, too easy and too general, but there's something that's true about it. So, you know, some of these programs are developing, and I think what I'm trying to bring across is, you know, take care of your partnership, and if you need help, seek help. Yeah. Okay, thank you, Laura. So I really appreciate this. You know, it's such a huge amount of data, and it's so difficult to make sense out of it. So I really appreciate that you've tried to really find patterns and understand, you know, what's getting worse, what's getting better, and what really represents some of the main challenges for the kids and the families. So what can we learn from Prader-Willi syndrome research and translate into Schaaf-Yang syndrome? You know, we're somewhat in a lucky situation, in this challenging situation that we're in, that we benefit from decades of research that have been done in the field of Prader-Willi long before Schaaf-Yang was discovered. And a lot of studies, you know, that have been done on Prader-Willi can, at least in part, be translated back to Schaaf-Yang. So we realized, you know, Prader-Willi, it's been known for a long time that many of these kids have growth hormone deficiency. So we actually asked that question early on: do kids with Schaaf-Yang have growth hormone deficiency? We did blood tests, and we showed that IGF-1 levels and IGF-BP3 levels, which are hormones that reflect growth hormone deficiency, are low in kids with Schaaf-Yang syndrome. Growth hormone has been FDA approved for the treatment of Prader-Willi syndrome and is one of the mainstays in treatment of Prader-Willi syndrome since 2000. And it's very important to realize that it's not just about longitudinal growth and the kid growing to a certain height, but it actually has so many effects on the body, including kind of shifting in body composition by decreasing fat mass, increasing lean muscle mass, gives the kids more muscle strength, more exercise tolerance, more endurance, more stamina, improves lipid profiles, maybe improves glucose profiles, and may also increase physical and cognitive functions. So many of you kids have been on growth hormone. This is Trinity. The Hanners are not here this year, but Trinity was one of the first kids that I knew was started on growth hormone, and there are only a few months between those two pictures. Some of you may have seen these pictures on Facebook. I think it beautifully shows what happens with growth hormone to the body. You know, fat mass decreases, lean muscle mass increases, and what you cannot see in this picture, you know, Trinity made tremendous progress within just a few months. She made developmental milestones that she had not made in, I think she was like 12, 13, or 14 years at the time. She was able to ride her bicycle. She was walking much longer distances, you know, things for which she just didn't have the strength and the stamina before. And we've studied that a little more extensively. This was retrospective, but this was questionnaire-based, and many of you participated in that study, where we send out questionnaires to families whose children were on growth hormone and to families whose children had not been on growth hormone. And we compared the data. So not to go into too much detail, but what you see here is the kids who were or were not on growth hormone, at the time they were born, they had the same height. But at the time they were enrolled, we could already see a statistical difference, a statistically significant difference between the kids who were not treated and the kids who were treated. Those who were on growth hormone, a z-score of 0 would be the average in the population. They are close to the average. Those who were not on growth hormone, they had a decreased height. They were shorter compared to their peers. In the lower graphs, you see the progress that is made and how height improves and increases over the course of the treatment. And you see a statistically significant difference even after 3 months, and then even more after 6 months. So that's shown here, time after treatment starts down here. And then we see that growth hormone has a positive effect on body mass index. So BMI score at the beginning of treatment, 3 months later, 6 months later, BMI is decreasing, and again, 0 would be normal. It's moving towards normal. The change in BMI score is here and looks even more dramatic there. But then again, there's more to growth hormone than just growth and body mass index. Growth hormone has a positive effect on strength and stamina. And we ask you, did you see a change in strength? Did it decrease strongly, moderately? Was there no change, or did it improve? And strength, stamina, and the overall satisfaction of the growth hormone treatment was generally good for those families. Now, what can we learn from Schaaf-Yang syndrome research that may be, translated into Prader-Willi? So one of the things that we found out, again, with your help, because many of your kids donated skin biopsies to us, which we then reprogrammed to become stem cells again in the lab, and then we used them to differentiate them into neurons. They taught us that there are some molecular alterations in those cells and neurons of your children. And one of the pathways that we had been investigating was the mTOR pathway, which has many important functions in the cells. And we had some indications that the mTOR pathway may be dysregulated, and mTOR can be addressed with a drug that's called rapamycin. In fact, mTOR stands for target of rapamycin, and rapamycin is a drug that decreases the activity of mTOR. So this is what I meant, this is what we do in the lab. We take the skin cells of your children, we reprogram them to become stem cells again, and once they're stem cells, we can differentiate them theoretically in all different kinds of tissues, but we are mostly interested in neurons. And Yanis, who's also here today with us, is one of the students in the lab who's working on induced pluripotent stem cells and eye neurons of Schaaf-Yang syndrome. And one of my previous PhD students in Houston, Emmeline Crutcher, she found that the morphology, so the shape of those neurons is different in Schaaf-Yang compared to healthy controls, such that the number of intersections and connections that they form was decreased. Importantly, when she treated those cells with rapamycin, so red were the Schaaf-Yang cells, and then green were the controls. When she treated the Schaaf-Yang cells with rapamycin, they were back to normal. So she could rescue that neuronal phenotype by treating them with rapamycin. An important question, does this also work in a living organism? And Laura, who just presented, and Henning, who's a postdoc in my lab, they've been looking into this, and they have been treating mouse models of Schaaf-Yang syndrome, both prenatally and postnatally with rapamycin, and looked at, what it does. Now, I should say not all of the effects of rapamycin are good. And in part, they found out that when you give rapamycin prenatally or very early in life, it can actually slow down development and cause developmental delay. But we also had some positive findings. So these mice are actually put on treadmills. It looks funny, but it's actually true. It's a picture from our lab. So they put on treadmills, and we see, how fast can they go and how far can they go before they kind of, slide back and fall off. So on the treadmill, the MAGEL2 knockout mice, they get exhausted earlier and they travel less. So this is the distance traveled. Their healthy siblings are up here. The Schaaf-Yang mice are down here. And the exhaustion time, how long can they stay on? The Schaaf-Yang, the healthy siblings are here. The Schaaf-Yang mice are here. They get exhausted much more quickly. When we treat them with rapamycin, so red is the healthy mouse that's treated with rapamycin. It doesn't do any harm there. When you treat the Schaaf-Yang mouse with rapamycin, you get to the yellow bar. You can rescue almost back to the normal level, both for distance traveled and the exhaustion time, which may be something, promising in the future. But many other phenotypes were not rescued. So we also do, like, we put them in the gym and they have to basically pull weights. So we have them hold a bar and then we pull on their tail and we see how long we can pull until they let go. So this is called grip strength. Grip strength, they also have a deficit, but that, for example, was not rescued by the rapamycin treatment. So it's certainly not a fix for all. Leslie, you have a question. Yeah. So rapamycin and mTOR, that's a pathway and a drug that gets a lot of interest in the neurodevelopmental community. If you read more about it, you will realize it's not just unique to Schaaf-Yang, but other neurodevelopmental disorders have also been discussed to be impaired in mTOR signaling. And for example, rapamycin is now used in tuberous sclerosis, which is also a neurological genetic disorder. These kids have a lot of seizures. And when you give them rapamycin or a drug that's similar to rapamycin, you can decrease the amount of seizures that they have. This is a study that has come out of Texas Children's Hospital, colleagues of mine. So certainly something to be investigated further. But as always, it's more complicated than you would hope it to be. We do not see the upregulation of mTOR in the mouse brains at all times, and it may not apply to all areas of the brain. So there's much more work going into this, and then the detrimental effects of rapamycin early in life. So what we are considering is to do a short-term treatment of rapamycin in older mice to see if we can still rescue the treadmill phenotype, and we may look into this a little further. So I'll keep you updated on that. And then there's new lines of research in the Schaaf lab. One of the nice things about working in an academic lab is people come and go, and there's new ideas that come into the lab. And so Ferdinand Althammer, who is a postdoctoral researcher in the lab, he just joined in January of this year. He's actually an expert on oxytocin signaling. So oxytocin is a hormone that is known as the social hormone, plays a role in social bonding, has been discussed in autism spectrum disorder and others. So Ferdinand, who's just coming into the room, and Moritz, who's also a medical student in the lab, they are working on the oxytocin system in Schaaf-Yang syndrome and Prader-Willi. In fact, Ferdinand joined the lab as an oxytocin expert because he wanted to learn more and do more for Prader-Willi and Schaaf-Yang. He is proposing a very kind of comprehensive research program to investigate the effects of oxytocin in Schaaf-Yang syndrome and Prader-Willi syndrome. And just a week or two ago, we submitted a grant application to the German Research Foundation, which, if it gets funded, would allow him to start his own lab and do Schaaf-Yang and Prader-Willi research for the next 5 years in Heidelberg. So everybody keep your fingers crossed. Yes. If it doesn't get funded, we'll come back to you guys, and you'll have to do a lot of fundraising and sell a lot of sausages, I assume. Yeah. So, and again, like what applies to rapamycin and critical time windows also applies to oxytocin. In fact, there's a group in France, Françoise Muscatelli and Maïté Torbert. They have investigated the effects of oxytocin in Prader-Willi syndrome, and they have actually given intranasal. It's beautiful because you don't have to poke needles into those patients. You can give intranasal applications of oxytocin, and they have given that to newborns with Prader-Willi syndrome in France, and they've shown that their sucking behavior improves. They get better at sucking and drinking milk, and then they're doing long-term follow-up, and their early data suggests that there are also positive effects on development and social interaction, just due to the application of oxytocin very early in life. So again, there may be critical time windows, and that's also something that we will investigate further. So with that, trying to summarize it all, I've shown you that Prader-Willi syndrome and Schaaf-Yang syndrome are both molecularly and clinically or phenotypically related. Schaaf-Yang syndrome may actually be more similar to Prader-Willi than we had thought 8 or 9 years ago. I have shown you that growth hormone proves to be beneficial in both entities. And I think that in every child with Schaaf-Yang syndrome, growth hormone should be considered. It doesn't mean that each and every child needs to get growth hormone, but we should sit down and discuss and think about whether it may be useful to your child or not. And many have struggled with getting insurance to cover growth hormone. If you do struggle or get rejected, reach out to us. We've written letters, we've sent our paper to the insurance companies, and in many cases that has helped. We're further investigating the mTOR pathway and rapamycin, and there are new lines of investigation, in particular oxytocin and many others. And it has been so rewarding to sit together with that international group of researchers today. And we've had many ideas. So, I mean, none of us will go out of business in the next few decades, because there's so much to be learned. And we are forever grateful to you, because most and everything that we have learned about Schaaf-Yang syndrome, we've learned from you and your children, and we are very, very grateful for you kind of, working with us together. I see us as one big team with one common goal, and that is kind of improving the quality of life of your children. So with that, thank you to my team. You see Henning, who's here. You see Ferdinand, who's here. Moritz, Yanis, and Laura, and then others who are also kind of working to advance Schaaf-Yang research. So thanks to all of them. And obviously, nothing we could do without your support, your children, and the Foundation of Prader-Willi Research. And here are some of the pictures from our meeting in Vegas. And when I come back next year, I'll show this year's picture. So thank you. Do you have any questions? Yes.
All right, endocrinologist, I have a general question. There continued adrenal monitoring recommended just once, and if they don't find anything wrong, that's fine.
What is recommended?
Adrenal monitoring.
Adrenal monitoring. So the question of a pediatric endocrinologist, whether adrenal monitoring would be recommended, like to be continued. So this kind of relates to something that is the most severe manifestation of endocrine abnormalities that we can see in Schaaf-Yang syndrome, which would be pan-hypopituitarism. So basically, from centrally, the entire hormonal system is messed up, including thyroid and adrenal glands and, many other hormones in the body. I don't know the answer to that. I feel like if pan-hypopit and adrenal insufficiency is not present in the first 2 years of life, I have not heard of any kids who have developed it later in life. So I don't think that, regular monitoring, like getting blood draws every 6 months or so for adrenal hormones would be necessary. But is something that has not been, systematically evaluated. Yes, please. Okay, so I'll repeat what I understood. Then Nathan was blowing a raspberry up here. So if I understand you correctly, has anyone investigated how neurons develop, like prenatally and postnatally in response to rapamycin or oxytocin treatment? Yeah, so a lot of this has not been done, and longitudinal studies in that regard have not been done. It's actually one of the key questions also that we have to ask ourselves. What we see in your children, how much of that disability is due to, let's say, damage that has been caused during the early development of the brain, which may not be rescuable, versus how much of what we see is the effect of like an ongoing dysfunction that could be rescued. Like comparing it to a computer, if the computer is not working, how much of that is a hardware issue where the wiring is just messed up, but you can't really fix it, versus how much of it is a software issue. If the hardware is fine and you just reboot the computer, everything is working beautifully. So it's the question of how much is a neurodevelopmental defect versus an alteration of what we call neuronal homeostasis. And a lot of research will have to go into that. And that will also relate to, how much of a clinical manifestation can be rescued. When do therapies need to be applied to have the potential to rescue? Michael, you had a question?
A question about rapamycin. Is it synthetically made and administered to the mice, or does the mouse make it more human thing and just under stress?
Yes, so the question is, is rapamycin something that's synthetically made, or is it a substance that the body produces itself and it's just deficient? So it's actually a synthetically made drug, and rapamycin is not anything that the body produces itself. Yeah. Matt?
Okay, so what you talk about is introducing other therapeutic options, but you also mentioned at the beginning of your talk that you have an internal gene function-based spine. Talk about at some point potential try to turn that on. Where is research in gene therapy?
Yes. So the question that's asked is about, which other therapeutic option there could be, and considering the fact that each child does have a normal, healthy copy of the MAGEL2 gene in each and every one of their cells, which is the maternal one. And what is the potential, and where do we stand in research regarding what we call unsilencing of the maternal allele? So it seems to me that, that is one of the, could be one of the most powerful avenues for therapy for your children. And there are projects looking into that. In fact, there is an FBWR funded project by a group in Australia. The PI is Marnie Blewett, and Marnie actually collaborated with us. We had one of her PhD students in my lab in Heidelberg for a few months. Then she went back, she took the iPSCs of your children with her to work on those in Australia and try to unsilence the maternal copy of MAGEL2. Marnie and her team have made some progress, and they have another gene in mind that they show that when they basically inhibit that gene, it kind of increases the expression of MAGEL2 and other genes in the Prader-Willi locus from the maternal allele. But it's not prime time yet. Also, the preliminary findings have not been published. But it is a therapeutic avenue that is actively pursued. You had a question.
Is there any understanding of why the mutation around 1996?
Oh, so the question is, why is that one mutation at C1996 so prevalent? So I think it's just because of the nature of the sequence of letters at that place. There's this run of 8 C's, 8 letters C, one after another. And if I, gave you a text to transcribe, and I had 8 C's in there, I bet 1 or 2 of you would drop a C or add a C because you kind of, miscount. And that's what happens in the body. We think the polymerase that transcribes the genetic code, gets stuck and just adds a random letter because it didn't count correctly. And the body is actually good at catching that in most cases, but every once in a while it goes unnoticed. And that's, when one is added and passed on into the sperm, and then, the child may have Schaaf syndrome. So someone else. Yeah, Karen. Oh, sorry, your name is not Karen? Oh, Stephanie. Your mom's name is Karen, right? Oh, I'm sorry. Yeah. Oh my goodness. See, I do know the Schaaf family, but not good enough. Yeah, I'm sorry. Yeah, so the question is, how far along are the clinical trials of oxytocin in Prader-Willi? So I'm not entirely sure. I think there are ongoing studies in France by that group. but I'm not sure where they stand exactly. Ferdinand may have a better answer. So just for the recording, so Ferdinand says he thinks the study has been completed and they're working on like evaluating the findings, and part of it has already been published. Yeah, but I do think there may still be ongoing investigations of oxytocin in Prader-Willi syndrome. There's also, I mean, again, it's more complicated because there's compounds that are similar to oxytocin, but not quite, that may work even better. So there's some are looking into carbetocin, which is like a compound similar to oxytocin. But again, also that avenue of therapies is actively pursued. Yeah, and it's actually, you know, it's interesting because this is a question that we have and a question for you, you know, with a group of patients that is fairly limited, you know, 300 sounds much, but you are scattered all over the world. And, you know, it's not like we have 300 kids that are 2 years old, but we have kids who are just born 2 years old, 5, 10, 52. You know, when we do plan a clinical trial, we need to focus, and we will define certain age groups that we will be able to enroll into our clinical trial. So we cannot do an unlimited number of trials, right? And this is something where we should, nothing that we need to answer today, but something where we should stay in touch and also hear from you and get engaged in a discussion of what we think may be promising, and also what you think is something that you want to see happening, or something where you feel like, you know, this is really meaningful because it's a clinical manifestation that has a great impact on our life, and we want to see that rescued. And, you know, so not to waste all the resources on something that's not meaningful to anyone, but to decide, you know, do we want to go for an oxytocin trial? What are the outcome measures of an oxytocin trial? You know, social interaction is very difficult to quantify. Should we try rapamycin? You know, if, you know, our results, they suggest that it may not, you know, treat everything, but, you know, if they're on a treadmill longer, you know, those kids who can walk, then it's something that we can easily quantify because we can measure how long did they walk, how far did they walk. And if, you know, stamina and endurance is something that's, you know, important to you, where you feel, yes, you know, we should go for it, then we should think more about, you know, coming up with a clinical trial for that. And then we're in touch with pharma about whole different groups of compounds that may have promise to help with pain sensation, that may be able to help with transition in the gastrointestinal tract and help with constipation, and others that may also help with social interaction. So something where we need to stay in touch and discuss. And I'm sure there will be clinical trials that we will all engage in the upcoming years. Yes. Oh. Yes. So the question is, you know, what are the chances that there are many more cases of Schaaf-Yang out there? And, you know, what could be the spectrum of Schaaf-Yang, right? So there's no question that there's thousands of people with Schaaf-Yang out there. You know, when you look at the distribution of cases, we have many cases in the US, not so many in Europe. In part, that's because exome sequencing became available in the US much earlier than in Europe. For example, in Germany, only 6 months ago, exome sequencing became available and paid for by insurance. You know, up until 6 months ago, you could only get exome sequenced through research studies, basically. Other countries like the Netherlands, where it's been available for many years, they have more cases of Schaaf-Yang than Germany, even though the country is much smaller, but they were found. So that's one thing. But then there may also be a much wider spectrum of the condition. And, you know, I talk to you only about the truncating mutations. We do know that there are many people out there who have what we call missense mutations of MAGEL2, which means they also single letters that I changed, but they don't cause a truncation in the protein. They just change like one building block in the protein, one amino acid. And there are many out there, and it's hard to make sense out of them and determine which ones cause disease and which ones don't, because each and every one of us has hundreds to thousands of genetic mutations, right? Nobody has a perfect genetic code, but which ones of those cause disease and which ones of those don't, it's not always easy to determine. But we actually have one medical student who's not here in Chicago. He's working on the missense variants of MAGEL2, and he's been in touch with families and looking at extended pedigrees and testing multiple individuals in the family. And I think I can say now there are individuals with missense variants that cause a disease. Whether you call that Schaaf-Yang or not, I don't know. It seems to be a little milder than what we see with the truncating mutations. In particular, most of those individuals do not have contractures, but they still have a high prevalence of developmental delay, hypotonia, and autism spectrum disorder. So it may be just a mild version of Schaaf-Yang. So yeah, there's much more to be discovered out there. Roya? Yes. So the question is, are there any studies that look at genotype, phenotype correlations, connecting the specific mutation with the level of severity that they experience? So one of my students from Houston, John McCarthy, looked into this in 2018. And that has been published. It's a study on 78 individuals with Schaaf-Yang syndrome. And, you know, we know that one particular mutation, C1996 del C, so when you're missing a C, that causes a very severe phenotype. Those kids have congenital contractures of the whole body, and most, if not all of them, die either before birth or shortly after birth. It's very severe. And then what he also showed is that kids with C1996 dupe C compared to all others who have different mutations are a little more severe compared to all others, but not drawing conclusions for individual mutations. So the more cases we identify, the more powerful these investigations of genotype phenotype correlations will get. And we're probably at a point, because that was in 2018, now we're in touch with many more patients. It's probably something I should find another medical student to work on. So yeah, it just never stops. And then we need to keep them all engaged and make them like an army of physician scientists working on Schaaf-Yang. Yeah.
I think the question got brought up in the session beforehand on the history, status of separate from Prader-Willi registry.
So this is a question about the Schaaf-Yang registry, and this is probably a question that I cannot answer. You know, we in Heidelberg at my institute, we keep a very limited registry, which is mostly, you know, who has gotten in touch with us, what is the mutation that was found, what's the contact information of the family, so that we can get in touch with you when we have new studies that we're starting. What you mean is the Schaaf-Yang registry that is kind of attached to the FPWR registry. And I don't know what the status of that is. Maybe Kim knows. Yeah. So we need to ask Teresa Strong. You know, Teresa is the one to ask. At some point, you know, there was also discussion whether to kind of tag team with the Simons VIP, the Simons Foundation, or to tag team with FPWR. And Teresa would know, you know, what's the current state, and also because that's actually important, you know, in the long run to collect that information, also to collect longitudinal information, you know, how does the phenotype emerge and which, you know, medications, therapies help the most. So that's an important goal, you know, for the next years, to have a better and more comprehensive registry. Absolutely. So yeah, get in touch with Teresa.
In number 29, I'm fancy having like
I think something just getting recorded.
so here's like here, the thing we should circle back with her down there. Yeah, we were definitely, and I know that you said it was like the difference between being on the PWR waivers and having her home with time and they were just looking up where that it's like never been the nation.
Yeah, like it wasn't either class wasn't easy and weren't sure what was for the child doing group. So
But now we could be going into the path with more patients. So this could be another like have a conversation. Yeah.
Good. So again, for the recording, you know, there have been discussions in the past. At that time, the decision was made to go with the Simon's VIP project because they have a lot of resources. They have genetic counselors who can get in touch with the families and do like a comprehensive evaluation. But that was shortly before the COVID pandemic. So the whole project kind of got slowed down very significantly. And it's a discussion that the group will pick up again and will decide whether to kind of, you know, reactivate that project with Science VIP or whether to go a different route. Yeah.
The Hal Fountain family, yes. Are they going with Simon VIP?
So the question is about the Howe Fountain syndrome and whether they decided to go with Simon's VIP. As far as I know, the Howe Fountain group has not made a decision yet as to, you know, how to build a patient registry. That's as much as I know, but we should ask Bo Bigelow and his team, you know, where they stand. Yes. Mm-hmm. So the question is like, how do we feel about investing money into identifying more individuals with MAGEL2 mutations? I don't know. You know, it's a very critical step early in those developments. So when you only have a handful of patients, either that project dies or you find more patients. From our perspective as researchers, it doesn't really matter whether we have 300 or 400. I think we are at a point where we have so many questions that we just need, you know, manpower and resources to address those questions. We don't necessarily need many more patients. On the other hand, you know, there's a lot of good things that you can do because many of you have been on a diagnostic odyssey and it may have taken longer or not as long, but, you know, there's good things that you can do helping people find the cause of their children's disease. And it's probably not one of the main priorities from our side, but something that the community may feel is important. And then, you know, that could be addressed. So, you know, offering exome sequencing in underserved countries or looking into specific cohorts that have been, you know, already identified and where DNA samples may be available, like large autism cohorts, you know, to take them and say, well, we know that a lot of kids with Schaaf-Yang have autism. So how about you take individuals with idiopathic autism and look how many of those have MAGEL2 mutations. Things like that could be done without too much effort, actually. Okay. Oh, okay. So the question, if I understand correctly, is there a benefit of getting diagnosed with autism spectrum disorder if that diagnosis has not been made yet? From our side, it doesn't matter. But I realize that, especially in the United States, that autism diagnosis is looked for and sought after because it seems to open doors towards therapies that otherwise you would not have had access to. It seems particularly in the United States, an autism diagnosis is kind of like a door opener to various types of therapy, because it's also a term that people know and understand, versus when you tell them my kid has Schaaf-Yang syndrome, they, you know, have blank stare. Yeah. You know, fortunately, autism spectrum disorder is not considered as stigmatizing in the United States as it used to be. In Europe, I see this is quite different. You know, people are not as actively searching for an autism diagnosis because there it's actually perceived maybe a little more stigmatizing than in the United States, or there could be other differences. But I know that some families have sought the diagnosis, or they have actively pursued that because they felt that they would have access to therapies then. Yeah. Yeah. So this question is, you know, is there overlap between autism research and Schaaf-Yang research? I would say certainly there is, right? I mean, also some families ask, well, does my kid have autism or Schaaf-Yang? Well, you know, autism is a clinical manifestation, right? It's a symptom almost, yeah. Kids with Schaaf-Yang have developmental delay, and some of them have autism spectrum disorder, and they can have constipation. One is not exclusive of the other, right? It's part of the syndrome. Regarding your question, Matt, I do think there's a lot of overlap between autism research and Schaaf-Yang research. We see that, you know, the Simons VIP, so the Simons Foundation for Autism Research, is actually interested in MAGEL2, and MAGEL2 has been assessed and is considered a bona fide autism gene. That's why they support also research on Schaaf-Yang syndrome. And then when we look at oxytocin, you know, oxytocin trials have gotten a lot of attention in the autism field. A lot of clinical studies have been performed on individuals with idiopathic autism, giving them intranasal oxytocin. So there's yet again an overlap to our field of research. Some of those trials have not been successful, maybe in part because the group of patients that were enrolled was very heterogeneous, and some of them may have had an oxytocin deficiency versus others who didn't. And then again, it may have been heterogeneous in regards of age, and some of those kids may have been beyond the critical time window when oxytocin needs to be applied to really be helpful.
Then that's a second question. What we do
So that question is, what can you as a community do to help us? So I think we've come to the point where we're doing really well in regards of like interacting and helping each other, right? So as I mentioned before, we need to identify ourselves as one group with one goal. You know, we try to find answers for you. We learn a big deal from you and your kids. You can always help us when we send out, you know, the 15th request to fill out a questionnaire, to fill out that questionnaire yet again and email it back to us, participate in our research. You know, there may be time points when we need more biospecimen, blood samples, lumbar punctures, skin cells. Be open to that and, you know, talk to us about your fears and hopes. You can certainly continue to raise money. I mean, that is an important aspect for us. Henning and Ferdinand, their salaries have each been paid for a year due to the funds that have been raised by you. You know, this is wonderful, and we're most grateful to that. And the more money you raise, you know, the more people we can hire to do MAGEL2 and Schaaf-Yang research. And I feel that works really well. And then what else can you do? Engage with us and, you know, take your kids, put them on the lap of each one of those students and postdoctoral researchers, take pictures and ask them to put that picture up on their bench, and they will remember. Yeah, so it's actually happy hour tonight for all the parents while the students will babysit your kids. Yeah, I didn't tell them. Yeah, so what I mean is get them emotionally attached to your children and to MAGEL2, because, you know, for many of them, up until 2 days ago, MAGEL2 was a gene, a protein, a project, but there was no great emotional involvement. And I've realized for them over the last couple of days, you know, it has changed their perspective and it has increased their level of motivation to keep going. So, you know, please keep doing that. So with that, I will stop the recording and I'd be happy to take more questions outside. So thank you for everything that you do.
Well, we want to say thank you to you and your team for coming here. You are so engaged with our families, and we're so happy that we can have all the communications that we have with you and how much you give to our families. And I know it's all about the community, and it's so great to see new families. And as we grow, it's good to hear the input that you guys give us, and I'm glad that we can give you what's happening here. I guess you have something being presented to you.
Well, I don't have your chef jacket because of something, but you officially have an I Got a Guy sausage jacket to take with you. And
That's awesome. Thank you, guys.
thank you, Doc. Thank you.
I will wear that with pride. Yes.
But thank you again, and safe travels home, and say hello to your family and to your team. We wish you guys the best too, and thank you for all you do. If you want to keep adding to that, if you need help on fundraising goals, I'm the one to talk to.